Hi there. So thank you for the chance to talk with all of you during this obviously very hard time for all of us. I'm a family doc by training, and I grew up professionally working in Camden, New Jersey. As some of you probably know, there's a PICO affiliate in Camden, Churches Organized for People, that's now converted into more of a statewide chapter. So did a lot of work with them over the years and started and ran a local healthcare organization. I've transitioned in the last 3 years to UnitedHealthcare, and my job here is in the Medicaid arm of United. And I've been at United housing people experiencing homelessness who are United members. So we pay for their housing for up to a year and move them into an apartment and wrap services around them, and also do home-based primary care. So my work's been focused on how do we do unique and different specialized care models for vulnerable people. So we're thinking a lot about this. We've got some very sick people across the country that may be living at home on a ventilator, maybe experiencing quadriplegia, maybe a brain injury, or recently off the streets and in an apartment. So just lots of concerns for this, folks. So Gordon, whenever Gordon asks you to do something, for those of you who know Gordon, it's hard to say no. So that's why I'm here and happy to help out. I think what I would want if I was in your shoes would be straight talk, meaning like, what is the deal? How bad is this? How bad could it get? And what should I be preparing myself, my family, and my community for? And so I'm going to do that. And I just want to be just clear with all of you that, it's, I guess if, you could have a caveat here, what you're about to hear is, is serious stuff. So, some of you may be keeping up with some of the deeper news about this, or some of you may not. And I feel like everyone around the country I talk to is at different levels of like, how serious is this? So I really feel like it's important to level set. So, and I'm going to give you citations for these things. And some of these are lay citations that are easy to read, and some of them are from like CDC and other sites. So the first question is, how infectious is this? And there's some great writing that is really easy to understand on Vox. That's Victor Oscar X-ray, vox.com. And the question is, how does this compare to seasonal flu? And let's talk about how infectious this is. In epidemiology, there's a word called R naught, which is how many people will one person infect. And on average, for flu, one person will infect 1.3 people. And for an infection to spread, for an epidemic to happen, you have to be more than one. And then when it falls to less than one, either due to social distancing or due to a vaccine, then or more and more people have immunity, then the infection will peter out in the population. So flu is 1.3, meaning on average, flu will infect 1.3 other people. And think about how widespread flu is. We think that the R naught for this is 2 to 2.5. So this is probably twice as infectious as flu. And that's what people are saying, that this is just really easy to catch. And there have been now many sort of beginning to be studies of like just how easy this is to spread. And I want to be clear, we don't understand everything yet. You're going to read lots of stuff flying around, and truthfully, it's just going to take a while to figure all this out. And it can live on different surfaces. Clearly, a metal or plastic surface is going to live longer than on a cardboard. The other thing is incubation time. So flu incubates for about 4 days, and then you start to show symptoms. This can incubate anywhere from 1 to 14 days before you show symptoms. Now, the challenge with that is that during that incubation time, you can be infectious. So we think that this is a very unique illness in that there is a lot of asymptomatic shedding of the virus and passage of the illness from someone who is asymptomatic. That makes it really, really hard, because think about all the things we've been doing of checking temperatures and, and that's certainly important. Clearly, what we know typically about viruses is that when you're looking really, really sick, you're probably shedding more of the virus. But just want to be totally clear here, there does appear to be viral shedding even when you're asymptomatic. The other challenge that we're seeing around the country is that, as I talk to my colleagues, how people show up is really variable. So, you know, it'd be much easier if people showed up and they all had fever, cough, and you know, sort of fatigue and those sorts of symptoms. People are showing up with just shortness of breath and nothing else. They're showing up with no fever at all and just chest pain. They're showing up with GI symptoms. So about 10% of people just present with GI symptoms. So the presentation of this illness is quite variable, which is making it a lot harder to deal with. The hospitalization rate ranges anywhere. So the hospitalization rate for flu is 2%. So we're not talking mortality rate. We're just talking ending up in the hospital. The hospitalization rate for this is 19%.
Wow.
The case fatality rate for flu is 0.1. The case fatality rate for this is anywhere from 1 to 3.4%. So, you know, this is much more serious. So the dismissive comments about, oh, this is just flu, it's not. And the thing to realize is that, you know, the word novel coronavirus is really important. This is a novel virus for which we as humans have not encountered it and don't have any background cross immunity or something similar that can like help you fight it off. So that's the challenge that people are having. So I want to pivot to the next topic, which is as this is growing, we have to make guesses about the trajectory and what's going to happen in a week, 2 weeks, 3 weeks, 4 weeks, 8 weeks. Probably a couple of days ago, you saw a really extreme, pretty intense pivot all over the country, right? One moment people are like, oh, not that big a deal. And then all of a sudden you saw the president, you saw governors, like just a big pivot. And I want to be clear that, you know, that's because there have now been more and more studies and projections about what's likely to happen in the coming weeks. And Shoshona, am I able to screen share to show you?
You should be able to, yes.
Okay, here it is. Let's see.
The green box at the bottom coming up for you?
Yeah, I think I'm bumping into some privacy setting. Here we go, figured it out. Okay, let me tell you where this is and you can look at it yourself. This is also in Vox, and this is projections drawn from studies at Johns Hopkins. And essentially what it does is it compares different countries and the trajectories day by day by day that they've had. And Hong Kong has totally fallen off. Singapore, totally fallen off. You know, relatively very few cases. Japan had some rise, totally falling off. And Korea had a very rapid rise and is beginning to fall off. Italy, Iran, Spain, Germany, France, and the US are all on the exact same trajectory. Italy is just about a week ahead of us, 10 days ahead of us. So if you want to know where we will be in a week to 10 days, look at Italy. And the reason that that's happening is that it takes a certain amount of time, say on average 5 to 7 days for the incubation period. Then there's a mild period of the illness for about 5 days, 7 days. And then at that point, you know, people declare, they either like end up being part of the group that just, this is a self-limiting illness, or the 20% that end up sick enough that they need to be admitted to the hospital. So that's why all of our projections have been difficult to do, because you, whatever you're seeing today, you know, it's very multiplicative in the days to come. So what you're seeing in Italy is they are running out of hospital beds and they're running out of ventilators. And a very basic treatment is oxygen and ventilation. So let me pause here, and I want to ask Shoshona, like, do I is this what you wanted? And I don't mean to scare people, but I also think you're all leaders in your community. You're going to have to figure out how to translate this for your own communities. But I also think to not understand what's about to happen would be a grave mistake, because things you do today can have a huge impact on mortality, can have a huge impact on adaptive and coping skills. So if we don't understand how serious this is about to get, then you're not going to understand what you can do to mitigate some of this and keep it from getting worse than it already is going to. So let me stop, Shoshana. Is this what you wanted?
Yeah, I think the first thing is, like, everyone understands. I think, like, today in Indiana, Governor Holcomb just announced a few hours ago that schools will be closed till May 1st. 2 days ago, a lot of people thought they were going back in 2 weeks. And a lot of folks have been focusing on just getting their folks inside. So I think it's helpful, like, could you share with us sort of like the phases? So this is something that I've heard, and I don't know if this is right, that like phase 1, flatten the curve, phase 2, the actual outbreak, and then phase 3, recovery. Maybe it's something else, but like, how would you help us understand? So right now you just said, like, so it's serious. That's what I heard you say. And then, like, what should we expect? Like, are we going to be in our houses for like 10 months or 3 weeks, or like, like what are some of the likely scenarios in terms of like how we understand the disruption in life, and like who we need to protect from what and why?
So a certain percentage of the population is going to need to get this before it peters out. So that could be a number like 60 to 70% of the population needs to. They're one of 3 trajectories. We get to that percentage and then it peters out. Option number 2 is we get an effective vaccine that has partial or complete immunity, and that R naught starts to drop. Step 3, or the third scenario, is we all stay cooped up and continue to do this social distancing. So if you look in China now, they had no new cases. All the new cases are from people coming back to China, but they haven't gone back out again. As soon as they go back out again, then the smoldering and the fire will start. So the challenge that we're going to have is that, we can't live indoors forever, but we're either going to have to end up with 70% of the population has had it, which would result in millions of people dying, or we all stay indoors until there's enough supply of vaccine for that to be widely distributed. Or the third small possibility is there's an antiviral treatment that probably isn't going to be used by mild cases, but would be used by severe and blunts that. So that's a third possibility as well, where the whole population's going to get it, but at least we can do something to deal with the extreme. The whole idea around blunting the peak of the curve is to slow this down enough that the healthcare system doesn't get overrun and we can keep up with it. The difference between 1% mortality and an 8% of mortality is supply of beds, supply of ventilators, supply of nurses, and good nursing care. So if we slow this down, then at least many more people will survive. We'll be able to keep up with the flow of this. And, we as a society and a healthcare system won't be overwhelmed. The hard part about that is the decisions you make when nothing's going on. Like, everyone looks great, everyone's healthy. Because of that 10 to 2 week delay, what you're looking at right now is not representative of what the future looks like. The other problem is the message has gone out to young people that there's nothing to worry about. And there are 2 consequences to that. One is they're out and about and they're spreading it, and they're going to injure their parents and grandparents. The other problem is that it statistically has some impact on young people. So the idea that it has no impact isn't going to be true. Young people are getting hospitalized. Young people are experiencing mortality from it as well. So the message needs to be out. All ages need to be indoors. It's for you, it's for your family, it's for the community. And we can't wait. It's got to be now, immediately, widespread, and it's got to be really like locked down. It's okay to go out to go for a walk. You should go for a walk. Doesn't mean you like meet all the neighbors and meet up. You can go for a bike ride, but you should socially distance. And you really should only go out to the store for absolutely critical things. If you can get it delivered, that would be much better. If you're symptomatic, you should not go out at all. And I'll tell you, I was at the checkout line at Aldi, and the woman doing checkout was coughing and not doing that well. And, you know, I came home and wiped everything down and wiped myself down. And so this is
Wow.
out there and spreading now. Now.
So can you tell us, I'm going to ask a few specific questions just because of time, because I know we only have you for a little bit. So I know that you worked with Gordon on this framework around treatment, care, or testing, treatment, and then support for people. What do cities and states need to be doing now in order for, like everything that happens in our community is structurally racist, right? And like the people with the least amount of power have the greatest potential, right? Folks in our jails, undocumented immigrants, folks that aren't housed. I think there's like a general question, like why is testing important? What needs to happen with treatment? And then what's the racial equity lens around what cities need to be paying attention to in order for everybody to have access?
Yep. So I'm worried. I know you all are worried. During times like this, you know, we already have lots of inequality and inequity, and it could just get worse. So Gordon's done a really nice job in kind of framing out a response. And his first kind of big bucket is truth. And truth is really like, let's all be honest about what's going on here, about the level of threat, and not mince words, because you know, people need to know how serious this is so they can respond appropriately. So the amount of mixed messages here about the risk is really a mistake. We've got to close non-essential businesses, and I'm totally aware of the impact on poor people and minimum wage and low wage jobs. I completely get it, and we're going to have to do a lot to mitigate this, but we're going to have to shut down as much of this stuff as possible. So that's the first item. The second item is getting widespread testing, and we're beginning to see all of this come online. There's a significant growth in it. There will be a lot of drive-through testing, the way that Korea really scaled testing with drive-through. There could end up being eventually door-to-door testing, but I think because of the donning and the doffing and the equipment and the safety needed, most of this is going to end up happening in these kind of walk-through or drive-through centers. It is going to be hard to get testing out to every nook and cranny. So I think thinking creatively about how to get people connected to testing is going to be a real challenge. And to be clear, it's just getting off the ground. So I think in the next kind of days and weeks, thinking about how FQHCs get access to this and vulnerable shut-in populations get access. To be clear, one school of thought amongst clinicians is if you've got the symptoms, you're probably positive. Don't waste the time and energy right now trying to test everyone because it's so prevalent. We've got to move to mitigation. But the way Korea really did stop this was testing lots and lots and lots of people so that the population like heard this and it became loud and clear. Let's pivot to treatment. Really, really good nursing care and just love and caring from your family makes a big difference. It made a big difference in the 1918 pandemic, and it's going to make a difference now as well. The next step is going to be some level of folks are going to have to be hospitalized, and they'll either end in a hospital or we'll end up with large, probably facilities that are big open rooms like the pictures you've seen, just because they're going to need overflow. In that case, just close attention and in some cases oxygen. And then the next stage is going to be people on ventilators. So unfortunately, the treatment for this is just supportive care. There are not treatments that involve medications yet at this point, and lots of efforts going on around that. And I think you'll see some changes. Where you all have a huge role to play is making sure that the bills that are getting passed, both nationally and regionally and locally, are taking into account high risk vulnerable populations. And I think Peak of Faith in Action can do an incredibly important, role in that, and all of your local efforts and state level efforts. And that's a long dialogue. And I think your leaders are driving that and have great thoughts in that. The last piece I would say is you've got to keep yourself healthy. This is going to go on for a long time. There may be moments when you do something which increases the risk of your exposure. I would argue that, Faith in Action needs you, your communities need you, stay healthy. You don't want to get taken out in the first inning here. We might need you in the fourth inning. So please don't do stupid things and sacrificial things like, all of us will make sacrifices and risk benefit choices, but I would just say to you that, just be really thoughtful about the role that you play and the importance you play in the community and the level of exposure and risk that you're choosing to expose yourself to. Shoshana, let me stop there.
Oh, that's good. Just so folks know, so Gordon is am I on mute? Gordon is the policy director, or has been the policy director for Faith in Action and deputy director for like 15 years. And so when that is who he's referencing. He has just a few minutes because I know he has a 6 o'clock call. If folks want to ask questions in the chat, we can create that to be the easiest way for me to see those and then ask him. Please do. If there are any questions, just go ahead and write those.
I have a question.
Pastor Washington.
Thank you. We're supposed to have a funeral at my church on Monday. What happens?
I think this is going to be the most, painful thing I could possibly say, but you're going to have to convert it to a virtual. And the reason is that you don't want to be looking back a month from now when the folks that came to the service end up getting sick. And it's going to be so painful and leaderly and hard to stand up and say that and do that. But I really believe it's in the best interest of everyone. And the sooner we get good at love and compassion virtually, it will be a skill and a muscle that you're going to need. And your parishioners may get mad at you, and the family may get upset. There's a really good article about of multiple members of a family in New Jersey that were struck down and how they're wrestling with.
Read it this morning.
Yeah.
Someone's asking, if you get infected, can you get reinfected after the first time?
Here's the problem: is that the coronavirus family is the same as the common cold, and no one's ever been able to make an effective vaccine for the common cold because it mutates so quickly. And this is already probably 19 strains. So we'll probably get something that gives partial immunity, either a vaccine, or if you get it, you'll probably have partial immunity. And maybe you don't, it's like the next time you get it isn't lethal. But no one knows yet. It's still pretty confusing.
So when you think about this quarantine, is that like the next year or the next 6 months, or like what do we anticipate is how this might most likely play out?
I would plan for 6 months, and I think
6 months in shelter in place.
Yes.
Oh my God, you're the first person to tell me that. Okay.
Look, I would love to be wrong, so please come back and be like, Jeff, you were like totally off base, but in my mind, I can't. So the two real scenarios out of this are a vaccine, which would think about how much time it takes to produce vaccine for 4 billion people or 300 million people, like really big deal, and then administer that. So that takes time. And then if we get medications, they're going to first be available to the sickest, and then we're going to want to test them. Giving out a medication to all of us is a big deal. Like, it's just going to take time. Like, we're going to have rapid production of treatments that are medication and rapid production of treatment that's vaccine, but it'll be experimental. You're not going to want to give a drug that can hurt people to lots and lots of people. So it'll initially be used on people who are, end stage to try and save them. It's just going to take time.
I have a quick question. What about what about the people that are saying these are just mild symptoms? One of the Prince royal person reported yesterday that it was just blah, that's all, not to panic. And I'm wondering, what do we need to do to make sure that not everyone feels this way, that some people are really, having bad symptoms that is putting them in dangerous zone?
It's really hard. The symptoms are all over the place, ranging from nothing to something to severe, and it changes pretty quickly as well. So it's the hardest part about this illness as a clinician, is that it presents very differently in different people. And you're right, some people just have malaise. Some people only have shortness of breath, nothing else. Some people only have diarrhea. Some people have a mix of all those things, and it's just so different person by person. There's no standard symptomatology, and a whole bunch of clinicians are getting infected because they're seeing people who don't have the standard presentation. Like a patient older who came in with chest pain, when they did a CAT scan, they found that the lungs were filled with fluid. It was really COVID, and had no fever and not even shortness of breath. It was just chest pain. So there's been a bunch of stories like that of really unusual presentations that's hard to nail down.
So one of the things that we've been working on, Faith in Indiana, is reducing incarceration. Why is it so important to get people out of jail? I know some states have already released a lot of people. There are still children in ICE detention and families in detention. What's going to happen to them if they stay there?
It's a bad day. It's a bad place to be on a good day. It's a terrible place to be in a pandemic, right? So we're going to have compassionate release of lots and lots of people, ideally. And that's a great example of something that, groups like yours can lift up and never waste a crisis. And if we can get some prison reform out of this, that's a good thing. Frankly, that's our society is going to be permanently transformed probably coming out of this. And let's come out of it better. Let's come out of it with universal healthcare. Let's come out of it with housing for everyone. For God's sakes, 100,000 people experiencing homelessness with COVID in California is going to be a catastrophe. Let's come out of it with better pandemic preparation. Let's come out of it with less income inequality. It will never be a better example of how dangerous income inequality is for everyone, not just the poor. So, I guess the best way for me to end my comments to say in an optimistic way would be, if society is going to be permanently different out of this, for God's sakes, let's make it permanently better and not worse.
Mm-hmm. That's great. And why is it so important that, you had a lot of focus on neighborhood testing, neighborhood treatment, particularly in low-income communities and immigrant communities? Why is it important that those resources are local? And, in Indianapolis, vote centers are in 3 places in our state. And
Yep.
Grocery stores, don't make it into a lot of our communities. What will happen if we don't have neighborhood clinics where people can get treated, or the testing doesn't go door to door?
Yep. So infections know no boundaries. They don't know national boundaries, regional, local boundaries. So, we're all in this together now, and every person that catches this is one more person who can spread it. So, I think it's in all of our interests to figure out how to make services available to everyone in different languages and different cultures. And let's be honest, society's not very good at that on a good day. So it's going to take all of us in a lot of different ways, stretching in ways we may even be uncomfortable, unusual allies and friends, and just ways that we're going to just pull together and get this done.
That's great.
I have a question. Sorry,
Go ahead. I was going to take
I
one
can't
more.
type in the chat box. I'm driving. So what's the difference between testing and screening? Because if you're testing everyone, it seems like that's screening. And then what is the benefit of testing people if we don't actually have treatment to treat them?
That's a fantastic question, and we're all debating that too. And colleagues in New York at this point think it's so prevalent that they're not even doing testing. They're just, assuming everyone's positive. I think it makes people take it seriously, and you start to size the problem, and you can also count your progress. So I'm going to just guess what the folks in South Korea would say is that if you don't know the size of a problem, it's hard to know if you're making progress. So I'm not sure, to be honest with you. I think that's probably right. Like it's, having people know like, oh my God, that was COVID. I better stay indoors, or I better not infect my family, is probably a good thing. When we go back down and have far fewer cases, then we get back to like contact tracking and, containment at the individual level. Then obviously it's critical again as well. So you're asking a great question. And it seems to me society is going to take this more seriously if we are doing testing. And also when you call a doctor and say, I'm short of breath and positive COVID, maybe systems will work quicker. I don't know.
Well, Dr. Brenner, I know you have to jump onto a 6 o'clock call, so I want to respect your time. And I also just really want to thank you for taking this time with us and with Faith in Indiana. I learned so much, and I thought I knew what was going on. So I just really appreciate how important it is right now for us to know the truth so that we can actually prepare our communities to respond and make sure that everyone comes out of this as healthy as they can. And I love your vision that we're going to be forever changed as a society. Let's make sure we come out on the other end better.
Absolutely. I'm here for you guys. And, I have so much respect for what Faith in Action does. So thank you for what you guys are all doing every day. It's all of us are going to be doing hard work. So take care of yourself. Keep safe.
Thank you.
Thank you, Doctor.
Okay.
God bless you.
Bye-bye.
Okay. So before we go into groups, I just want to share a little bit about what we were talking about. So this is a framework that could be really helpful in thinking about how do we make sure that there's equitable access. So one is truth. We want to speak honestly about what's happening. I don't know about you, but that was the first time I actually heard what we can expect. That people need to have access to testing, local treatment, and when we do enter recovery, all along the way, we want to make sure that the most vulnerable families are able to protect themselves and their loved ones and weather the hardship. The low-wage workers, people that require paid sick time and family leave, unemployment insurance. We should not be having ICE raids right now. We should not be filling our jails and prisons. All of those things are critical choices that, frankly, can happen at the city and state level. Part of why we're in this situation is because of our the lack of leadership in the federal government. So we are grateful that governors in Indiana have stepped up, and mayors, and we want to make sure that that continues all across the state. I want to share a little bit about what we know right now about how we're preparing in Indiana. Let me see. So today was an announcement about saying that we're going to be closing schools until May 1st. You might have heard that from the governor today. Indiana, as of like 2 days ago, Indiana was one of the least aggressive states in guarding against the COVID virus. So we ranked number 10 least aggressive in the country. And Trump, as we all know, is continuing to try to divide people with race to deflect responsibility. So this is a quote that he tweeted out. The Chinese virus is very serious, and I've done everything from the beginning. Talking about the Chinese virus is about trying to use xenophobia to drive division so we don't focus on the wealthy elite who are benefiting from this. Let's not forget that Trump knew about this in November and made choices not to act. And so we're in this position because of the leadership gap, and they're going to continue to try to get us to blame each other so that we don't act together for the kinds of changes that we need. So I want to suggest that there are 3 things that I think are really critical that we begin to think about, and Reverend Linda is going to break us into groups to sort of debrief what we heard and think about what this means for our communities. But I want to lift up 3 things that have always been our role as faith leaders, that as this narrative of division continues to roll through, that we know that we get through this together, that we belong to each other, that all of our lives are connected, that there's an abundance if everyone shares, that we have a narrative that we need to counter. 2 is, now that we understand what we're up against and the long-term nature of this, I want to suggest that part of the strength of our congregations is our relational infrastructure. And though we might have to be physically separated, we want to recreate relational structures as much as we can so that people are in continued ongoing relationships, so we can take care of each other, get people what they need, provide spiritual support, and act as needed. And the 3rd is, that we lifted up on this call, that there are concrete things that cities and states can do to make sure in the next few weeks that we're as well prepared as we can be, particularly for the most vulnerable populations in the state. So I don't want to go in too much into the details because I think we're all kind of processing where we're at. But I want to just suggest that those 3 things continue to be part of our role as prophetic leaders. Reverend Linda, do you want to break us into groups? Stop share.
Yes. Thanks, Shoshana. Wow. Taking a few deep breaths on this part of Indianapolis. So yeah, I think that for me, I kind of, going back to what Rabbi Brett said at the beginning, I know that I feel both this kind of intense desire and need to care for my congregation, but then I also feel, what has always been our call as Faith in Indiana and as leaders, to look to those people in society who are most at risk and most vulnerable. And so